Today my topic is flexible endoscopy. It's very broad and ambiguous topic to talk for 20 minutes. So I'm going to briefly talk about the current status and future perspective of flexible endoscopy. Okay, my talk will be as shown in this slide: brief history of GI endoscopy, structure of flexible endoscopy, and current status of diagnostic flexible endoscopy, and current status of therapeutic flexible endoscopy, and last future perspective. Okay, before starting, please see this advertising copy in 1907. Even if patient were transparent, your doctor couldn't see enough. I think this copy is well explaining the needs of endoscopy. You may be surprised if you hear that Hippocrates examined the gastrointestinal tract around 300 BC. He describes examination of the rectum assisted by candlelight. The first true endoscopy was designed and built by German physician Philipp Boccini in 1885. However, it was never used to human. It used a candle as a source of the light. At that time, people did not understand this procedure, and he was reviewed by medical faculty of Vienna and punished for his curiosity. 50 years later, a French surgeon, Antonin Jean de Sormeau, first introduced the modified Boccini's endoscope to the patient. Now he is considered the father of endoscopy because his instrument had three fundamental elements of modern endoscope: meters, lens, and the light source. Of course, the light source was lamp flame, so its major complication was burns to the patient. In 1932, Rudolf Schindler developed a gastroscope in which the proximal end was still rigid, but the distal end was capable of being angled up to 34 degrees. Of course, now it's more than 100 degrees. In 1950s, after glass fiber developed, a few industries started to produce flexible endoscope. It was impossible to record the finding. However, after gastrocamera, an endoscopy combined with camera was released, we can record the endoscopic find at last. In 1980s, the development of video endoscope enables live images to be displayed on a video monitors so that other doctors and medical professionals can observe diagnostic and the therapeutic procedure as they are being performed. Currently, the rapid development of digital image processing technologies expand the diagnostic and therapeutic potential of endoscopy. Okay, now let's take a look at the shape of and the structure of flexible endoscopy. The structure of flexible endoscope is composed of 5 basic sections: light guide connector, light guide tube, and control body, and insertion tube and bending section. Each section is constructed differently, but each has a protective outer layer and hollow inner area that contains the delicate internal systems. Let's look at the light guide connector. This light guide connector is the solid end of the scope that connects to the light source or video card system. The suction, air, water, light, video system, and electrical ground all connect to this part. And this light guide tube, this hollow tube connect the light guide connector to the control body. Multiple layers of steel coil, fiber mesh, and vulcanized rubber are bonded together to make up this tube. A thin layer of clear polyurethane is applied to the tube for chemical and fluid resistance. The light guide tube provides protection to the delicate internal components such as suction channels and fiber optics. The control body, this section of the scope contains the position controls, angulation control knobs, air, water, suction control valves, remote video switches, and biopsy port and focus mechanism for fiber optic scopes. So insertion tube, this insertion tube is a long flexible tube inserted into the body during normal use. The insertion tube is hollow and provides protection for the delicate internal components, including angulation system, fiber optics, and video signal wires and biopsy channel. So with rigid scope, we only could see the esophagus and rectum. Since the semi-flexible, we could see more stomach and sigmoid colon, jejunum, ileum, pancreas, bile duct could be observed since fiber optic flexible endoscope. So currently, we can see not only entire gastrointestinal tract, but also adjacent structures, extraluminal structures, and perform something therapeutic. These are conventional white light endoscopic findings. Findings in first law are normal finding of GI tract. Left side picture of second law is ulcer. Middle picture of second law is rectal polyp, and the right side picture of second law shows colon cancer. Sometimes we can get additional information from magnifying endoscopy. Maximum magnification power of this scope is 80 times. The recent development of magnifying endoscopy has enabled more detailed observation of various gastrointestinal disorders. This picture shows background non-carcinomatous mucosal surroundings, carcinoma, which has regular microvascular pattern plus regular microsurface pattern. Okay, this picture shows carcinomatous mucosa, which has irregular microvascular pattern plus irregular microsurface pattern, with the demarcation line, see arrows, between cancerous and non-cancerous mucosa. If you see these two pictures, you can realize how close you can see the microvascular and microsurface pattern with the magnifying endoscope. Okay, now narrowband imaging, NBI, is also being used more and more to make better diagnosis. NBI uses two discrete bands of light, one blue at 450 nanometer and one green at 540 nanometer. The narrowband blue light displays a superficial capillary network, while green light displays subepithelial vessels, and when combined, offer an extremely high contrast image of the tissue surface. The capillaries on the surface are displayed in brown, and the veins in subepithelial areas are displayed in blue. Okay, these are a picture of a small colonic polyp under both high definition white light and the digital chromoendoscopy without magnification. This is a normal white light. This is MBI image. This is white light, and then this is MBI image. You can see the contrast between polyp and normal mucosa is increased using MBI.